Dear students, this is e-learning section with histopathology slides. Today's topic is endometrial cancer, endometrial carcinoma. The uterine endometrial carcinoma is the most common gynecologic malignancy in the US and in well-developed countries. The incidence is continuously increasing. 80% of the cases there's postmenopausal bleeding, and this is the first symptom. Endometrial cancers must be divided into two large entities. Type 1 endometrial cancer is endometrioid and mucinous cancers, and the tumors are associated with long-term unopposed estrogen stimulation like obesity, PCOS, exogenous estrogen, or tamoxifen therapy, usually in the background as KRAS or PTN mutations. Precursor lesion exists as endometrial intraepithelial neoplasia. Type 2 includes high-grade tumors like serous cancer, clear cell cancer, undifferentiated cancer, and carcinosarcoma. These tumors have a lesser association with opposed estrogen exposure, and serous carcinoma is characterized by p53 mutations. Serous carcinoma is the most important, and serous intraepithelial carcinoma has been proposed as a pre-invasive precursor. Back to type 1, we have to mention that estrogen stimulation, obesity, atherosclerosis, hypertensive disease, it's a very frequent combination of these people with age peak of 55 to 60. If we speak about type 2 cancers, these cancers usually arise later. The age peak incidence is around the late 60s or rather 70s. 30% of the cases we can see advanced stage. This is the FIGO staging. Metastases also occur to the bone, brain, liver, lung, and skin. From nodal metastases, the most common metastases are the pelvic and para-aortic nodes. According to local infiltration, the tumor usually spreads from the endometrium to the myometrium, first in a superficial fashion, then transmural spread can be seen, and the tumor later is able to penetrate to the uterine cervix and or to the fallopian tube. According to uterine endometrium cancers, use grading system to determine whether the predominant glandular pattern is presented or we can see solid component. The more glandular the tumor is, the better the prognosis. In cases of uterine endometrial cancer, total abdominal hysterectomy with bilateral salpingo-oophorectomy is the standard treatment. Regional nodal dissection is performed when higher grade is presented or lymph node involvements proved. Medical treatment with exogenous progestin is a valid option, but we shouldn't forget about the radiation therapy and chemotherapy. These adjuvant therapies are indicated for high risk of recurrences and or distant metastasis. So this is generally an adenocarcinoma with two prognostic groups, type 1 related to estrogen level elevation and type 2 diabetes, and type 2 endometrial cancer is rather a high-grade tumor with worse prognosis without severe correlation of elevated estrogen level. Endometrioid adenocarcinoma of the uterus is our slide, and we can see a cross section of the uterus. At the top we can see the tumorous change of the endometrium. We can see no preserved part of the endometrium. If we take a closer look, a glandular pattern is clearly visible with irregular atypical glands with desmoplastic stroma reaction, and this tumorous proliferation spreads to subserosal localization around vessels as well. This tumor, it's a low-grade endometrial cancer, endometrium adenocarcinoma. It's low-grade because we can see no nests, no solid component of this tumor. Only glandular pattern is visible. If we take a closer look, at least 40 times magnification, we can see the high cellular atypia with rounded nuclei with crowding in the glands and loss of polarity of the glands. We can frequently see mitotic figures as well, not only close to basement membrane, but in superficial position of the glands as well. On the right side of the picture we can see a leiomyomatous nodule. We have discussed its coexistence in the previous slide. Having the information that there's a low-grade tumor penetrating through the myometrium and the uterine wall, we have to consider if it's specific to molecular alteration such as microsatellite instability.